Hey everybody, welcome back to the ECG of the day. My name is Reed, and don't forget to download the PDF of today's ECG down from the description below, and to like and subscribe to the channel if you enjoy this content. So this is a pretty fun ECG. It doesn't look crazy when you look at it, but this one's got a lot of cool physiology. And so first thing we're going to do is just get an idea of what's going on. We'll look at the forest, and so I've maybe come down here to lead V5, and I see I've got a narrow complex rhythm that seems to be pretty regular, right? And you see it maintains its regularity through the entirety of the strip. My QRS is narrow, and so that makes me think that conduction throughout the ventricles is occurring from that AV node down my nice His-Purkinje system. And when I look in front, just to kind of get a glance, I see that there's a P wave there, but I don't see P waves in these ones. And then I see a P wave, and then I don't see a P wave. And I see a P wave, and look, notice I'm getting every other beat has a P wave, and every other beat doesn't have a P wave. Huh, it's kind of interesting, but it's a pretty regular rhythm. And so, might get my rate. I'll use this QRS on a solid line. I've got 300, 150, 100, 75, 60, 50. This is 43, so maybe 46 beats per minute. So we've got a bradycardia, right? So we've got a bradycardia here. So we know that when we work through bradycardias that are narrow complex, right, we think of, it could be one, it could be an AV block. Two, it could be a sinus bradycardia. We could have junctional escape beats, right? We know that the AV junction can produce an escape beat that occurs every 40 to 60 beats per minute, right? At that rate. And so let's work through this. Let's take a look. Let's evaluate those P waves. Well, what is the atria doing? And the P waves, right, they look like they are, this is kind of a last P wave, upright in lead 1. And in AVF, it looks like there's one kind of peeking out right there that would be upright in AVF, right? So these are sinus P waves, okay? So we've got a sinus rhythm. Next thing I do is I look at my intervals, my PR interval, which tells me about how my AV node is doing. And if you look here, you can see I have a normal PR interval. So my PR interval is in between 120 and 200 milliseconds, which is normal, okay? But I need to make sure that that PR interval stays the same the whole time, and right? And so I noticed that when it does have a P wave before my QRS, it seems to be normal. But now my job next is to determine, does every P wave have a QRS? And so V1 is a great lead for this. So what I notice is that, the ones that we have arrowed in green don't have a P wave. And so when you see a narrow complex QRS, that tells me that it's going down my His-Purkinje system, but there's no P wave in front of it. And so these are junctional escape beats, right? We know that since this rhythm is so slow, that makes sense that we could potentially have junctional escape beats, right? So all the ones that are arrowed in green are junctional escape beats. Why would a rhythm go from sinus, like this rhythm, this beat, to junctional, and then back to sinus, and then to junctional? Well, there needs to be something that interrupts the sinus node, right? The sinus node has to kind of slow down. And if you're noticing, what's happening is after all the junctional beats, which are, this one's a junctional beat, this one's a junctional beat, right? Every other beat we said is a junctional beat. Look at after every single junctional beat, what do we have? After every junctional beat, we have a P wave that is our sinus P wave, right? It's the exact morphology of our sinus P wave. So we have these sinus P waves that occur just after our junctional beats. Those are not retrograde P waves, because retrograde P waves would look different from our sinus P wave. Those are sinus P waves. Now I need to turn to my normal QRS beats, right? So like this one, and determine, why does this normal sinus beat lead to a junctional beat every time? Why does this normal sinus beat lead to a junctional beat every single time? It's happening in this perfect pattern. So what I do is I look on the T wave for any extra beats, and what do I see? I hope you see it. I see this I see that little spike. If I look again on my other sinus beat, what do I see? I see a little spike. And so I'm looking at all of my sinus beats. After all of the sinus beats, I've got this small deflection. And what is that small deflection? That's a P wave. And that P wave looks different than the normal P wave. So that is a premature atrial contraction. So we have premature atrial contractions that are occurring after every sinus beat. And what is that causing? Well, first of all, that P wave is being blocked, right? It's a blocked PAC. So we have a blocked PAC. Well, why is it blocked? Well, because we have our normal sinus rhythm that occurs with sinus beat, goes through the atria. The AV node takes it, delays it by a little bit, and sends it down to create our QRS. And if we have a PAC that occurs early enough and it depolarizes the atria, well, the AV node might still be refractory, and so if it's still refractory, it's not going to pass that signal down. And so that's what we're getting. We're getting blocked PACs because the AV node is still refractory. After the blocked PACs, we're getting a pause until we get a junctional escape. And then what happens is that junctional escape occurs right before the sinus node is ready. So we're getting a junctional escape, and then a little bit after, we're getting a sinus P wave, because the sinus P wave is finally reset. So we're getting this same cycle where we have a P wave that conducts to a QRS, and then we get a premature atrial contraction that is blocked. We get a pause, which then leads to a junctional escape that occurs just before another sinus P wave. That's the cycle. It's happening over and over and over again, right? Look at this here. We have our sinus P wave that conducts to this QRS. We have a premature atrial contraction that is blocked because it occurred early enough where the AV node couldn't conduct that signal down, and so that was blocked. We have this pause in our rhythm that leads to a junctional escape beat, because we know that the AV junction can occur in beat every 40 to 60 beats per minute. And just as the junctional escape beat happens, just a second later, just a split second later, we get our normal sinus P wave. Why is the sinus P wave occurring late? The sinus P wave is occurring late because this PAC, that PAC, when it depolarizes, right, whenever this red focus, when it depolarizes the atria, what does it do? It resets. It resets the SA node. And so now it resets the SA node, but it doesn't reset the junction. So the junction has an escape, but my sinus node has to take a little bit longer to reset itself. And so we get a blocked PAC that leads to this phenomenon. And so we're getting that over and over and over again. And so remember that, we're not done, right? We still get to evaluate that QRS complex. Let's evaluate it. My QRS is upright in lead 1, but it's down going in AVF. So my QRS axis is going like up and to the left, but it's not too far up and to the left. It's still positive in lead 2. So it's somewhere in this quadrant. So we have a little bit of left axis shift. That's okay. I don't see any evidence of hypertrophy that could cause that. It's narrow, so there's no bundle branch blocks. I've got good R wave progression. If you look through the recording, good R wave progression. And then my QT interval is appropriate. It's rate related, right? So if you look in between these two beats, you can see that the QT is appropriate. And then I don't see any pathological Q waves. I don't see any ST or T wave changes that make me think of ischemia or infarction. And so let's put this crazy rhythm all together, and what do we have? Well, we've got a sinus rhythm roughly at a rate of 46 beats per minute. And we have blocked PACs leading to junctional escape rhythms. And these blocked PACs, matter of fact, are occurring in a pattern of atrial bigeminy, right? Those atrial P waves are occurring every other beat. And so that's what we call those blocked PACs in a pattern of atrial bigeminy. So this is kind of a rare finding, but shows good, normal response to what should happen in this case, right? But this person has got pretty severe bradycardia, right? So we kind of want to work on that too, but maybe the bradycardia is due to some of these blocked PACs. Who knows? But I hope this helps. If you have any questions about this rhythm, feel free to throw them down in the comments. And if not, thanks so much for watching. Hope you learned something, and we'll see you on the next ECG video. Have a great rest of your day.